Hi, I'm Dr. Gerald Deas. Welcome to Health Center from Downstate Medical Center. Today we're going to discuss a very important condition, a medical condition, neurological condition called Alzheimer's disease. And what is it all about? You hear people mention it. Sometimes people can't spell it all together, but at the same time they can say Alzheimer's, and it was named after a psychiatrist years ago. And he found certain people had certain memory deficits or problems with memory. And so today we're going to discuss this condition, and which is right here at Downstate Medical Center. It's a very fine department in psychiatry of treating these patients, and how, if you feel after you've seen this program, you can get in touch with the right people to get the right diagnosis and the right treatment. So I want to sit back and just hope you can remember the things we say today. I want to mention now to introduce you to Dr. Cohn, who's in head of the Alzheimer's department here, and what he's doing and what this disease is all about. Welcome, Dr. Cohn.
Thank you. Well, it's always important to begin with what's normal memory and what's Alzheimer's. So again, as people get older, there's a tendency to get forgetful at times, and we all worry about it. And is it something that's a harbinger of Alzheimer's, or is it just normal aging?
Right.
And like the rest of our body, our brain ages, and we are apt to forget things. Mm-hmm. So you don't run as fast, you don't do other things as quickly, you're not as strong, and so the brain sometimes forgets things.
Right.
But Alzheimer's and dementias in general are something quite different. Mm-hmm. And they represent changes, serious changes in the brain. There are several kinds of dementias. Alzheimer's is the most common, representing about 70%. And Alzheimer's involves having abnormal proteins in the brain called beta amyloid and neurofibrillary tangles. But it's also characterized by a number of other kinds of symptoms, which I'll talk about in a second. Right. Let me just say there are other kinds of dementias that people will hear about. Vascular dementias, which represent changes in the blood vessels in the brain, or small strokes in the brain. Lewy body dementia, which involves dementia with Parkinson's disease-like symptoms. Mm-hmm. And Parkinson's disease itself often has dementia as people progress. And then there are other causes, and some of them potentially reversible due to metabolic problems, medical problems of various sorts. Depression can often mimic dementia. So it's always important to get a good evaluation to make sure there aren't things that are potentially reversible, mm-hmm. or at least partially reversible, that can improve somebody's condition. Now, the symptoms of a dementia, and sometimes called neurocognitive disorder, more and more you're going to hear that term, include problems with memory. You must have a memory problem to have a dementia. And it's usually evident as short-term, but even long-term memory may be affected. But because you have so much long-term memory, it's not always as obvious. Families typically say the person can remember in the past, but they can't remember something yesterday.
Right.
If you do detailed examination, you'll find the gaps in the past too. Mm-hmm. But the other things that people have are often language problems. They may have trouble naming things, understanding things, and quite severe, not the thing where we forget a word here and there.
Right.
Also, they have trouble with fine motor skills. They will have trouble increasingly dressing themselves. They may have trouble learning any new motor task, any skill. They may have trouble recognizing objects and people. And I like to give the example of the caregiver who's taking care of this person, their loved one, and they're slaving, they're like saintly, and then the person doesn't even recognize them. They say, "You're not my daughter, you're not my wife," and it's heartbreaking to see that.
Yes.
People also have some problems with their planning things, about how they think about the world, and when you walk down the street and negotiate the world, you have part of your brain's working pretty well, but when people with Alzheimer's and other dementias, they have trouble with that. And finally, the important thing is they have trouble in daily functioning. Starts out with minor problems. They may have trouble paying the bills. They may have trouble using transportation or shopping, and then it progresses to difficulties with bathing or feeding themselves. Now, there's also a condition that you'll hear more and more about now called mild cognitive impairment or mild neurocognitive impairment, where they may have memory problems. If we do some fancy testing, we'll find some gaps there. But their functioning is still pretty good. They seem to manage and to negotiate the world pretty well.
Right.
And some of these people, probably at least a third of them, go on to develop a true dementia. Third stay the same, and a third get better, seem to improve. So we're not quite sure what that is. And we increasingly have more tests to figure out what's going on. There's now some fancy PET scans that can pick up amyloid in the brain, or there's some measures of the cerebral spinal fluid. If you do a spinal tap, you'd find abnormal proteins in the brains of people with Alzheimer's. So we're getting kind of more sophisticated. We're not doing these tests routinely yet, but the potential may be there, especially as we believe that treating the disorder very early on may have the most benefit.
Now, when you say treating this, we'll get into a little treatment here, because a lot of times, before we get into the drugs that might be helpful, how do we maintain these people at home who have these problems and disturbing the whole family? I understand, Mr. Muhammad, you kind of jump into the picture at that time to when a person's finally diagnosed, and you obviously see it breaks up the home thought processes going on, and things can disrupt the home and the whole life of a loved one, taking care of that person. And how do you fit into this picture?
Very true, Dr. Deas. Well, the first thing is that you have to think about what support you have in your family.
Right, yes.
And often, in this society, family members are very, very busy.
Sure.
Fortunate for me, I had a friend that worked at Downstate who told me about this support group that Ms. Lorna Walcott Brown and Dr. Cohn have at the center, Brooklyn Alzheimer's Disease Assistance Center, which is affiliated with S.U.N.Y Downstate, but it's located right in community, right on 370 Lenox Road.
Right, yes.
And I don't live too far away, so it was a perfect match for me initially to go to the center, and then I realized how many services were there for me as a caregiver, and that was my lifeline. I met other caregivers, and it was like a crying room. We could cry together, but then also walk away with ideas and feeling supported and feeling that you're not alone.
Yes.
So that's what the first thing a family member has to do, is see what kind of support is available in the home, and then reach out in the community, because like children, it takes a village. Like the elderly, it takes a village. You cannot do it alone.
Right, right. And and if you don't have insurance, it means it's quite expensive to get a caretaker.
Well,
or
when you go,
caregiver.
as was said, the social service director gives you suggestions and ways in which you can look at your resources,
Right, yes.
that you can make some decisions on how to balance that so that you can get the care in the home. I was able to do that very successfully.
Do you find, African American, Caribbean Americans, we have a very strong, Haitian Americans, have strong religious beliefs and things like this. Have you been able to use them as a reach out program for them to help?
Well, a lot of religious institutions have supports in this, among the community, and certainly your friends within that religious system is supportive. But I'm not sure if they actually have, financial resources available or people in place. So for me, that wasn't available. So I went into the community, and I found, the Downstate had the services.
The services.
Yeah, I got emotional support from my religious community, but in terms of technical assistance, ideas on how to get a safe return bracelet, how to, just suggestions on how to, what kinds of services like recreational activities available for my mom, that came from the center.
Right.
Yeah.
Now, do they have a direct number they can call, say, speak to Ms. Mohammed to get some of this information?
Well, they can call the center.
Center.
Which is 718-287-4806, and speak to Ms. Lorna Walker Brown or the secretary, and that person will give further information.
Is that just for the Brooklyn community?
Well, it's for everyone.
Okay.
But it's more accessible to Brooklyn caregivers to go
see.
there, because it's near, Downstate is near all transportation, so it's easy to get to.
Right,
But
yes.
the center's open to everyone.
Well, I'm sure it's a blessing when they can get that number, and
Absolute perfect word, Dr. Deas. It is a blessing to go somewhere where you feel supported, because
Yes.
often you're not getting the support in your own home
Right.
because everybody's busy
That's
and
right,
everybody's interests may be different. So you go to the support group and everyone there is for the same reason.
Right, yes.
Because a loved one is changing, which is painful, and the loved one needs additional assistance and support. And you have to be the caregiver needs care.
Right,
so when you
sure.
go to the center and you're within the support group, you receive care. You're reminded that you have to go for your own medical treatment. You're reminded that you're not in it alone.
Yeah.
And I always walked out feeling so much better.
I know.
Yeah, I always
and I know
did.
that people do too. And that's so
Yeah,
important.
yeah, it's a group. It's a group effect, and when there's group, there's love and there's support and there's
Oh,
ideas
yeah.
and there are blessings. You're
Blessings,
absolutely
that's
right.
right,
You're absolutely
right.
right. Yeah.
Dr. Cohen, maybe a little treatment. How are they advancing in the treatment of Alzheimer's now?
Right. Well, there's several parts to treatment. Both the memory problems is number one. Number two is the behavioral problems. And
Right.
number three is kind of social supports, which we talked about for the caregiver and the patient. In terms of the memory problems, unfortunately, it hasn't been a good period over the last few years. We understand, ironically, as we understand more and more about the mechanisms of disorder, we still seem unable to find a really robust treatment. We've been using the same types of treatments now for about a decade, which include things like Aricept and Exelon, which you see on these commercials, which increase the amount of a chemical in the brain, acetylcholine. And they help minimally, but it's not a powerful treatment that we would have hoped. There's another drug called memantine, which we use, also called Namenda, which affects another chemical in the brain, and it helps a little bit as well, but again, not so robust. There was hope that these other drugs that would affect the beta amyloid, reduce the beta amyloid, or the processes that affect the beta amyloid would work. And
What is amyloid exactly?
it's an abnormal protein in the brain. We probably all produce some, but when people with Alzheimer's, it tends to clump more and change configuration a little more and not removed as easily.
I see.
Sometimes it may just be a poor sanitation system as in Alzheimer's.
see,
You don't get
yes.
rid of the abnormal protein.
Right.
But we thought if we could stop the accumulation of this beta amyloid, it would be cured.
Right.
And if you were a rodent, it seemed to work. They actually, in these rat models, it seemed to work quite well. And but it hasn't panned out in humans. They've tried antibodies to these plaques, and it just hasn't. Most of these trials have not been successful.
Has it anything been connected to the environment, chemically? I'm talking about food-wise, nutrition, vitamin deficiencies,
Well, there are
things like this.
Yeah, there are a number of risk factors. Clearly, one risk factor is genetics. If you run, it does run in families. There are some families where people get it very early on in the 30s or 40s, where it's a very strong genetic risk
Yes, right,
factor.
yes.
But most people, it's a milder risk factor, and there seems to be environmental factors, because one sibling will have it, another sibling doesn't.
Right, yes.
It's thought that some things could moderate it and perhaps reduce your risk. Exercise is very important. And
Isn't that interesting? When you say exercise, that also with heart disease, we find that there's certain cholesterol,
That's right.
HDL, the high density proteins, seemingly that has less collection of fat in the arteries. And
Well,
just by
they all well, it's interesting. Exercise, the Mediterranean diet, and reducing these risk factors like diabetes, hypertension, cholesterol, smoking. They all sort of overlap a little because they interact with each other. Those three are probably the strongest factors in potentially reducing the risk.
How about
and
blood?
People should do it in middle age, start
Right.
earlier, or young age.
Right,
but even in older age, it still seems to be able to reduce the risks.
How about blood groups? The A, AB?
Not that I know of. That doesn't
No,
seem to be...
Because, when they're looking at, there's whole books now written that you are what you eat according to your blood group even. And they find that there's different diseases that appear in different groups of people on the basis of their blood group. For example, the Mediterranean, when they started this whole measuring these blood groups, they lived near the water, so they ate more fish and they ate more vegetables and things like that. As they went inland, as man developed inland, then you start eating animals and things like this. You know, your whole diet changes and things like this. So I think that major work should be going into this kind of thing of blood groups and things like that. Maybe possibly making a prediction.
It may be another avenue because the amyloid story is not working as well as we had hoped. Now, some people are trying to target these neurofibrillary tangles, and maybe they're will help. Will be able to modify things.
Sure, Cowhill's disease, for example, is a particle that causes mental dementia. You know, Cowhill's disease. Every time I see people eating the Cowhill soup, for example, you know, because it's a viral thing. It's a virin thing that absolutely affects the brain and things like this, you know. And we might be doing things in our culture that's really promoting the thing, you know.
It very well could be. Certainly, the advanced nations, people see more risk for hypertension and high cholesterol and diabetes. All these things place you at higher risk for both Alzheimer's and vascular dementia.
Yes, right.
Now, the other part of the treatment is the behavioral problems, and often that's why patients are brought in, because they're out of control. They have become aggressive. They may be even hitting the caregiver. They're yelling, they're screaming, they're hearing voices, they're delusional, thinking people are stealing from them, or they may have very severe depression. Those things we are better able to treat. Now, here's where it's important for psychosocial treatment to come in. We try to get people to we try to get the caregiver to a support group so they understand what's going on and not provoke the patient. Sometimes that goes on, that they don't understand and they think the patient can still they're just doing it intentionally.
The patient is rude or just, you know, just antagonistic. And a lot of times after we get the education, we understand that that's part of the process of the disease.
The other part, of course, is to get the patient into perhaps a day program where they can get physical activities and some mental stimulation, things of that nature. And that requires some additional help, which again is provided by often shared in support groups of how to get on Medicaid, which is an avenue for getting into daycare programs and home care support and things of that nature. A myth among physicians and social workers and people in the community is that it's very difficult to get on Medicaid unless you're dirt poor. And the truth is, it's possible to go to an elder law attorney who can shift funds around, and you can buy into a very important program. Probably the most important thing you can do is to get on Medicaid.
That elder law lawyer who's trained in these things can do magnificent things for people. You can't just go to a plain lawyer or plain advisor and so forth, but when you know how to shift that law around to get on Medicaid, because it is an expensive disease for just paying the caretaker, you know. Ms. Muhammad, how do you fit into that picture?
Well, yeah, you're right. It can certainly break your bank. So you need to find, you know, ways to manage your money so that your loved one can get all the services that are available. Also, I think that Dr. Cohn mentioned the importance of education. The care group, within the caregivers group, we receive education. And with education, you always feel more powerful, you feel stronger, and you can make better decisions, because so much what happens with the patient, the loved one, is not something that you would expect. Because the loved one that you knew was vibrant, smart, you know, independent, and now with someone where the roles are reversed, where you now become maybe the mother, or the spouse. The spouse becomes the child is the patient's the child, and the spouse is now the parent. So it can be very, very painful. So with education and support and faith, the caregivers do so much better. So much better.
Now, I wanted to add another component of the treatment, which often people come to us for, is they're at their wits' end. And we often need to give some medication. Now, the problem with the medication, especially the ones we use, like the antipsychotics, they now carry this black box warning that says it's higher mortality rates. And that's pretty scary to a caregiver. We try to explain that the risks are only 1 in 50 to 1 in 100, but so it's not like it's some certainty or of some serious problem developing. And some studies now have shown that the risks aren't even there. You know, so we try to reassure the people about the medication. So most people are willing to give the medication because we tell them, and they recognize that there is higher mortality rate among caregivers. If they don't get some help soon, they'll die before the patient. They'll die before the patient.
Yes.
So we try to coordinate it with getting them into day programs and getting home care, but we also sometimes give medication, and we use low doses, time limited, and usually that will calm the patient down, and everyone is much feeling better. The patient is no longer in distress. The caregiver feels better. They can get the person often calm enough to go to a day program too. Sometimes they're just not calm enough, or they're getting thrown out of a day program because they're too agitated.
Surely.
And people go through different phases of the disorder. So at one point in time, they may be getting this agitation, and then a year later, it calms down, and they no longer need the medication.
Right.
So it's important to keep monitoring those things.
Surely.
What I like about the center with my mom is that there were varied approaches, and I learned through by being a caregiver.
Right.
We were fortunate to have 2 high schoolers from a neighborhood high school, Nazareth Regional High School.
Yes,
yeah,
right.
these 2 high school students were trained by one of Dr. Cohn's associates there, a social worker also, and they were trained how to come into the home to work with my mom. It was an intergenerational program. It was wonderful.
That's wonderful.
So they came in, they sang songs with my mom, played games, increased her conversation. So that was another very positive experience. And Brooklyn ADAC is constantly looking for new ideas, as well as the traditional, treatment, but new ideas how to improve the patient's mental state and so forth, and also, taking care of the caregiver.
Well, when you talk about exercise, do they use any dance therapy sometime with the patients?
Well, Dr. Cohn can talk about it. There is a patient activity
certainly
group.
at some of these day programs, they do dance and music. People retain that
a lot
longer.
of music, yeah.
Yes,
very
right,
good.
yes.
My mother loved
The areas
music.
of the brain that are affected by Alzheimer's, typically not the centers related to music and rhythm and that. And we often have people interestingly coming in late in the disorder singing hymns and tunes.
Loving that. Yeah.
By the way, I want to add something about the church, which I think is very important. We try to encourage the family members to take the person to the church because it's sometimes they're only outing in the week, and they see old friends and they recognize the music and the environment. I think it's quite therapeutic for them, and so it builds up social bonds with that the caregiver may be losing too. They may be confined to the house, and they need to be out there seeing their friends, and often getting some support
really
from the priest as well.
Sure. Well, that caregiver thing in a family is certainly important in making house calls, as I told you I've done. Sometimes they don't have adequate caregivers in the home, and it is very burdensome.
It's a long illness.
It's a long illness.
It's a long illness,
That's
and
right.
if you try to do it alone, it's impossible.
It's impossible.
Yeah, you're
And,
right. It's
it
a
will-
long goodbye.
It will
Very,
wear you out,
That's
as
right.
they say.
That's right.
Wear you out,
Completely. Burn you out. You're
Burn you out,
absolutely right.
and sometimes there's not that many children in the family, or if there are children, it always takes one child to do it all. You can have 10 children, only one is taking care of it. The rest of the children go off to different
That is
areas.
so
So,
Very true.
Listen, Ms. Muhammad, and certainly Dr. Cohen, it's good having you with us today, and to give a more depth understanding of Alzheimer's. Hopefully that the people will be able to call our offices again. Is there a number again that we could call?
718-287-4806.
Right.
There's also a website if you go to
Yes.
SUNY Downstate Brooklyn Alzheimer's Disease Assistance Center.
Okay. All right. Well, that will be on the at the bottom of our film
very
also.
good.
So
Yes.
you'll probably be deluged with a whole bunch of
Oh,
stuff.
good.
You know?
Services are there, and the community has to take advantage of it.
Oh,
The
yeah.
services are there.
So you folks, I hope you've learned a lot today. If you have a patient at home that has this condition, that there is help. There's financial help, there's help in the home. Take some of the advice when they have to be put on a medication, that medication might control certain behavior to be able to be more social in eating and looking at television or looking at pictures. But it's very important that you yourself become part of the treatment. And you can do that with many things, by just showing old pictures of relatives and things like that that they have known in the past, or play music, jazz, or hymns, or things like that that they are very familiar with. You'll see their eyes will brighten up as soon as they see that first note come across, and things like this. So it's up to you too to be able to take care of the patient at home, and also to be able to send them to places where they can get this kind of care during the day. You know, that daycare sitting is almost like babysitting the day, but it does work. And so I hope you've gotten something out of this program that will help you make your life easy, and certainly the patients. See you the next time.